Hello, and thank you for joining Everything You Need to Know About the Rules. So today we're going to cover a few standards from the college. You've sent us some great questions. We're going to try to get to them all. Due to the 1 hour period that we have for this webinar, we might not get to them all, but feel free to add or send us any further questions. Use the chat function on your computer. If we don't get to the questions, we will print the answers in the next edition of Perspectives in April. So my name is Fiona Campbell. I'm the Senior Physiotherapist Advisor at the college, and joining me today is Rod Hamilton, our Registrar. Rod.
Thank you, Fiona. Well, welcome everybody who's out there listening, and we hope there's a lot of you. It's great to be speaking with you today. And we just wanted to use this webinar to wrap up the series of roadshows that we've done over the course of the last year. We met with over 1,000 different PTs, students, PTAs, and others through the province. And we found that a really, really helpful and useful experience because, we've learned a lot of really fantastic things. We'll be starting that outreach program again later in the spring, and we look forward to seeing you all again. We find the outreach program to be incredibly valuable. It's really useful to find out what you're experiencing in practice, especially around what challenges that you're facing on an ongoing basis. And it's also really helpful to hear your questions about the rules and expectations that the college has established. I wanted to mention to you that we're working on and have set up a new newsletter for employers. And if you are an employer, or if you think your employer would benefit from reading that kind of content, please let us know. And in fact, you can send an email to us at communications@collegept.org, and we'd be happy to start you with a subscription to that email newsletter for employers. As you know, it's my job to ensure that the college is protecting the public, and that's the job of every registrar. And we're going to touch on a number of rules that we've established this year or in the last years to give you some sense of how those rules work and protect the public. And we'll run through a series of standards and expectations in that context. And as Fiona indicated, we've all received a number of questions, and I'm really happy how many we have received, and we'll try to do our best to respond to those questions right now. If you have additional questions or need clarifications, please use the chat line as Fiona indicated. Now, I'm going to pass you back to Fiona, and Fiona will start the real show.
Okay, so this is how we think it's going to work. I'm going to talk over the high level rules around the standard, and then we'll start taking questions. So we get a ton of questions around the standard working with physiotherapy assistants. And I think there's 6 key points we really need to understand from the standard. The PT always has the accountability for assessing the patient, for coming up with a diagnosis, coming up for a treatment plan, and if they need to involve a physiotherapy assistant in components of the care, then they'll need to sit down and discuss the role of the physiotherapist versus the role of the assistant and get agreement or consent from the patient to involve the assistant. If you're going to involve the assistant, the physiotherapist is also accountable to make sure that that assistant is trained, has the knowledge, the skill, the experience to deliver that component of care that the physiotherapist believes the patient needs. There must be a communication plan. Lots of questions about communication plans. It's quite simple. The physiotherapy assistant needs support. They need a number. They need to know how and when to contact the physiotherapist should the patient ask questions about their care, want to progress their care. That should be available to the assistant. There needs to be an alternate supervising physiotherapist if the original primary physiotherapist won't be available to the assistant, then you need to have a designated other physiotherapist that assistant can call if they require. Now remember the couple of other rules. A relative cannot work as an assistant for the physiotherapist, and a physiotherapist cannot assign the controlled acts of acupuncture, of spinal manipulation, or communication of a diagnosis. That's got to remain with the physiotherapist. So I would encourage, it's a 6-section standard. I would encourage physiotherapists to share this standard with employers if you really need to discuss, if you're seeing any issues meeting the standard, put that standard in front of the employer and have a discussion. So let's take some questions. The first question I see that was sent in, somebody asked, what might the communication plan between the PT and the PTA look like? I think we called it a protocol in the standard, and that made physios think it's something more than it is. And it really is just a number, a pager number, a cell number, and means that the physiotherapy assistant can get in contact with the physiotherapist. But remember, the physiotherapist and the assistant have to agree on what conditions would trigger an assistant to call the physiotherapist. An example might be the patient is asking about their treatment plan. They might be finding it too hard or too difficult. They need some adjustments. That would be when the assistant needs to call the physiotherapist for future direction on what to do with the plan. The next question. I want to know more about working with a physiotherapy assistant, specifically about documenting in the clinical records. I wonder if you're asking, can the physiotherapy assistant document in the records? And the answer is yes. Yes, they can, if the physiotherapist and the physiotherapy assistant have agreed and the physiotherapist has confidence in what the physiotherapy assistant is going to write in the record. They need to know, yes, that subjective, objective clinical data might be okay, but the analysis, the actual pulling together of any data or measurements, that's the physiotherapist's job. So that wouldn't be something the assistant would write. So the subjective, the objective, and any treatment that was delivered on that day certainly would be something a physiotherapy assistant would be able to document, but the physiotherapist needs to be confident that it's done and it's done accurately. Rod, I wonder if you can take the next one. Somebody's asking about any limitations on the number of physiotherapy assistants that can be supervised by a physiotherapist. My understanding, our rules do not give a limitation on the number of physiotherapy assistants that can be supervised. The physiotherapist needs to be confident that all of those 6 areas of the standard will be met if they're supervising a physiotherapy assistant. So yes, the physiotherapist would need to evaluate whether they could meet the standard and certainly consider how many assistants they would feel comfortable supervising. Do you have anything to add to that, Rod?
I think that really sums it up, Fiona. I think that really it's about what's reasonable to the people who you're supervising, what's reasonable to the people who are watching you supervise, and what's reasonable for your patient. You need to be confident that you can provide an adequate level of supervision to the people that you're supervising, and you need to do that in a context that allows you to meet the expectations of the college, and more importantly, that allows you to provide in conjunction with your assistants, safe care to the patients that you have showing up at your clinic.
I'll maybe take one more from this standard because I think we get a lot of questions around this alternate supervisor. So I wonder if we can address it and hopefully make it clear. Somebody's asking, I work, tell me more about supervising a PTA, the person asks, on weekends. I, as the physiotherapist, I'm not on site or I'm working somewhere else in the hospital. How would I, if I've assigned a physiotherapy assistant task today and the patient's status changes the next day, I'm not there to know about it. What do I need to do? So that's really, let's go back to the communication plan you have with the assistants. If you're the primary physiotherapist, you've assessed the patient, you've come up with a diagnosis and a treatment plan, you're confident in the assistant's ability to deliver components of that treatment plan. You've communicated with the assistant when they need to contact you or the alternate supervisor. So if you're not there or you're in another part of the organization and they can't contact you, at that point, if the assistant sees they come in the morning, the patient may have had a bad night, their condition has changed, or the patient's asking about their treatment plan, the physiotherapy assistant can't get hold of you, you're somewhere else, then there's a name available to them, that's the alternate supervisor. They would trigger call the alternate supervisor. That alternate supervisor takes a transfer of care. They then become responsible for that patient to either instruct the assistant to either stop care based on what they've told you, or you will then come, open up the patient record, collect some data, and make modifications to the care. You as the alternate supervisor who've done this work are responsible for that patient until the original or the primary physiotherapist is available and can transfer the care back to their responsibility. What do you document? The alternate supervisor should make a note when they've taken that transfer of care back, they've made alterations, or they've given instructions to the assistant. They should definitely document what their analysis was and what the future instructions were. All right, I'm going to go to the next standard if that's okay. Fees, billing and accounts. Now there is a recording. We had a webinar around the fees, billing and account standard. I really encourage people to go onto the website and have a listen. But if I can just say there's 5 parts to this standard. Again, we start off with the general theme. The physiotherapist is accountable for any billing or account that's made using their registration number, which means if a patient is coming into the clinic, the physiotherapist is accountable to communicate what the charges for those fees are to the patient. The patient needs to understand and agree to those costs. The physiotherapist also has to have a system or a written process in place where they check the accuracy, the honesty of the registration number when it's used for billing. Lots of questions about that. They need to write down that process, and there needs to be evidence that they're reviewing or auditing the billing. So that might just simply be taking a list of invoices or charges given to the patient for services and checking that with your own patient records on what you delivered and make sure they're accurate. If there are errors, and errors happen, if there are errors discovered, you need to take reasonable steps to correct those errors. Now, lots of questions about, can a physiotherapist offer packages of care? Well, yes, they can. They can offer a package for service, but they need to offer the patient alternative. They can buy single sessions if they want of treatments. And if they have any unused portions of the package of care, then there needs to be a system or a very transparent way of how much will be refunded for the care. So that's in a nutshell, that's the high level standard for fees, billing and accounts. And I'll go to some of the questions what we've received. The first one is, how often do we need to do the audit or billing of our records? Oh, context is everything. Perhaps you're a new physiotherapist, you've just started out at a new clinic. You might be doing more regular, more frequent audits, taking a list of invoices, checking what was charged or what was billed to insurance company and comparing it to the service you delivered on a particular day. You may have a high volume of patients coming through your clinic. So again, it may be more frequent billing. Some physiotherapists choose to do their audits daily. Some choose to do it monthly. But again, it's up to you to reason how often you will do those audits. And I hope that's clear. So how do we know if a wrong or incorrect billing happened in an MVA clinic? Well, again, you've got that process. You're going through regular samples of your billing, or maybe you're even doing all of the billing and checking that. I just want to say you can contact myself or the advisory service at the college, and we can run it's called a professional credentialing tracker report. We can actually run a report from the automobile sector to show when your billing number, your name and billing number has been used for billing, and I can run that report in a matter of minutes and send that to you. So more tricky if billing for extended health benefits. If you watch our webinar that we have posted, you'll hear an insurance sector representative talk about if you're suspicious at all that there is some billing going on that you're not in control of, you're not aware of, then feel free to phone the insurance carrier, the insurance adjuster, and talk through what your suspicions are. Rod, do you want to add anything to that?
Not really, but I think it's the thing that's most important about this is to recognize that you need to ensure that you have a clear understanding of what you're billing for, and so that if you look and find anomalies to that billing, or somebody informs you of anomalies to your billing, that you can be confident that those are not a result of things that have happened in your practice, that it may be either mistakes or some kind of willful fraud that some individual is perpetrating. So the most important thing is to have a clear understanding at all times what your billing should look like, so that you can pick up those problems if you see them.
Okay, I see another question. In fact, there's 2 or 3 questions around this whole PTs billing for services that are actually personal training sessions. So I'm going to try and address that. We've already talked about the standard for working with PTAs. We talked about a PT being responsible for doing an assessment, coming up with a diagnosis and a treatment plan. That's physiotherapy. Anything else is like personal training would not have those components to it. So if you're billing for personal training, that's wrong and that's not allowed. As a college, there may be components of the care. If the physiotherapist done an assessment, there is a diagnosis, there's a treatment plan, and components of that care are assigned to somebody who actually works as a personal trainer. They will still be working as an assistant, or the rule for working with assistant would apply. Yes, a personal trainer might be able to do those components, but we would still need to see that the physiotherapist is doing an assessment, a follow-up reassessment in a reasonable time, and that the patient has consented to that third person who is a personal trainer delivering components of the physiotherapy care. There is a question there, what is the college doing about the increasing number of fitness studios that are billing under supervised physio for training programs? I know, Rod, you may want to comment on this. If our viewers look at our discipline page, you'll see a few examples of what the college is doing. Maybe you can comment on that, Rod.
Well, I think most importantly, it's not the fitness, necessarily the fitness studios themselves billing. It's individual physiotherapists who are willing to allow their numbers to be used in this inappropriate way. And so we need to know about that. I mean, these kinds of issues are serious. They are not in keeping with the expectations that we've established. And so sometimes you may clearly understand that this is going on. However, we're stuck here and in the building, and we have very little access to those kinds of pieces of information. So if you're concerned and offended by these kinds of activities that you're aware of, then we would appreciate you stepping forward and letting us know. You don't have to make a formal complaint. You can call us and speak to us, and we can look further into it. However, the important thing to remember here is that if you're aware of these kinds of things, you should help us to deal with the issue, because it's not helpful for people who think they're getting physiotherapy care in this context, and it's not helpful for the profession and the way the profession is seen from the outside. So I would encourage you to act in that context, and then we will take it from there.
Okay, thank you, Rod. We have a couple more questions around can a physiotherapist prescribe orthotics without doing any particular course? I'll just take that one. If a physiotherapist has done an appropriate assessment and they believe that the patient requires orthotics, they may be able to, yes, recommend an orthotic. Do they need to take particular courses? As a self-regulated health professional, you really need to look at your own training, your own skill level. You need to determine whether you need any more courses. If the college came and asked you, how do you know you're competent to assess and prescribe orthotics? You really need to provide a good, reasonable explanation of why you believe you're competent to do that. So that would be, again, self-assessment. It's a responsibility of a physiotherapist. And maybe take one last question on the standard, if that's all right. Can I, as a physiotherapist, advise patients to take magnesium supplements to improve muscle cramps or fish oil to get better tendon health? Are we allowed to use modalities not yet approved by the FDA? Okay. I think as a physiotherapist, you really need to step back, and maybe I can recommend a document that the Canadian Alliance of Physiotherapist Regulators has on their website, over-the-counter drugs. I think you should have a look at that. We know that this is certainly an evolving practice. Be aware there's Schedule 1, Schedule 2, Schedule 3 drugs, and we certainly cannot recommend any of those. There are unscheduled herbs, supplements, drugs that we may be able to recommend, but they're the same point I made before. As a physiotherapist, you need to do a self-assessment. Do you really have the training? Do you really have the knowledge to be prescribing a herb or sort of recommending a herb or an over-the-counter drug? Do you really understand the interaction of the herb or the drug? I know when I did physiotherapy, we had some limited courses on pharmacology. I certainly would not feel competent in recommending a herb. So self-assess, can you? They're unscheduled drugs. Yes, we know that you're able to sell them in your practice, but you do know that a patient gives a certain value to a physiotherapist's knowledge and expertise. They may assume that you have the knowledge and expertise in in drugs or herbs. Be careful about that. Make sure that you are competent and you have the training before you are recommending any of these sorts of magnesium supplements or even over-the-counter drugs. I think that's all, and I'll maybe move to the next standard. Well, it's not actually a standard, it's digital health. This is a growing area that I found when I was out on the roadshow talking to physiotherapists. A lot of physiotherapists have said they've been involved in pilot projects for delivering care remotely. Other physiotherapists, particularly up in Thunder Bay, have been doing it for years. It was nothing new there. But be aware that physiotherapist more and more is being delivered using information technology rather than meeting a patient face to face. There's lots of benefits and there's lots of risks. The benefits to the patients are they can receive some care in the comfort of their own home. They can receive care, they might be in a remote destination, they might be way up north without access to physiotherapists, and they may now get access because they're using information technology to speak with a physiotherapist. The risks are, what competence do you need to deliver that care? Are you competent to use information technology? Is the patient able to use the technology on their end? There also, you need to have plans. For example, if something happens, the patient falls or there's a technology breakdown, what is your plan if that occurs? So a physiotherapist would need to start thinking around delivering care using that mode of service delivery. But I think bottom line, the same college standards apply. A physiotherapist, even if they're delivering care remotely, needs to be competent. They need to keep a patient record. They need to get consent from the patient to be delivered via a remote technology. Privacy, lots of questions around privacy. What platforms can you use? What do you need to think about when you're using information technology? I maybe hand over to Rod if you've got anything to add about privacy when you're using these certain platforms. I know we've had some conversations about that.
Yeah, and I think this is, as you say, Fiona, very closely related to the principles that underlie the keeping of medical records generally. And the thing to remember is that there's a what you must keep component and a how you must keep it component. And I can speak and give you a couple of pointers on the what, but the how is something that you need to think about yourself in conjunction with your hopefully IT advisors. But think about it as if you were keeping a record that you might keep on paper. And how would you, what are the principles that underline that need to keep that record? So first of all, you need consent from the patient if you're going to collect information about them to make sure that they know that you're going to keep information about them. And then you want to make sure that the information you collect is clear about how you're going to use it and share it with that information you've collected from your patient. You shouldn't be keeping it and sharing, or you sharing it just for your own curiosity. There should be good reasons as to why you're collecting it and sharing it. And then you need to make sure that whatever you collect is kept safely, and or in other words, confidentially. So in that context, if you were dealing with paper, you might want to lock it up in a cabinet and make sure that only certain people have access to it or keys to that cabinet and so on. And then you need to decide and understand how long you're going to keep the information that you've collected. Now, we have rules for that, but it's across the board similar, is you need to decide how long you're going to keep it. And then you just can't make that rule to say, well, I'm going to keep it for 10 years. You also then need to act on that rule at a certain point in time and dispose of it. So if you apply that same set of general principles across the electronic information that you collect and record and use ultimately, then you will be perfectly well prepared to deal with this kind of situation. But specifically how will of course depend on the kind of practice that you have, on the kind of technology that you're using in your practice. So I'm not going to tell you how to do it, but I think hopefully that's given you a little bit of clarity on the what you must do.
Thank you very much. And yeah, it's a good reminder. Certainly physiotherapists are asking lots of questions. It's good to see this evolving practice, and your questions are really great. Keep them coming. The next area is consent and capacity. And lots and lots of questions around how to get consent. How do you know the patient is really agreeing and understands what's going to happen in the physiotherapy session? So remember, it's the law of Ontario, the Healthcare Consent Act, that governs or provides the rule for all healthcare, all 26 professions, on how they have to get consent or agreement from a patient for anything that's going to happen during care. Patient, you need to be confident. This is really important. When you've described what you're going to do in a physiotherapy session, what you need to examine, the patient needs to understand. You need to pause and allow the patient to digest what you've just explained to them about physiotherapy and ask you questions. So it's almost like they need to demonstrate their understanding to you before you proceed with care. There's another rule in Ontario law, the Healthcare Consent Act really specifies if a physiotherapist is going to provide care to a patient, and let's go back to the first standard we talked about, working with a physiotherapy assistant, that's a third person. The law states clearly that if you're going to involve a third person in a plan of care, then that patient needs to understand the role of that individual, the assistant, what role they take in their care. They need to understand it and then agree to it before you bring that person into the treatment delivery. Remember, when you're getting consent from a patient for an assessment or a treatment, you need to explain the benefits of, of the care that you propose, the risks, the reasonable risk that you could foresee, any alternatives to care, and not having any treatment at all. So a physiotherapist sent me in just an acronym they're using, BRAN. I use that a lot as well. It's a good reminder of the components of consent that you need to remember, the BRAN. So one question we had, and I'm going to turn it over to you, Rod, and that was about, can you talk us through getting consent from a child? Is there anything special we need to consider there?
So Fiona asked me this question periodically because Fiona and I have been talking about this for more years than I want to remember. But in any case, I think what's important here is not necessarily just about children, but about the principles behind the consent generally. So in this context, I remember the first time we talked about this, we were at a joint meeting, and a physiotherapist who was in the audience asked us, well, why do I need to get consent when I know more about what the treatment should happen for that patient than the patient does? Can't I just tell them what I'm going to do, and isn't that enough? And so what I said was that what I want you to do is think about a situation where you go to a clinic and somebody, a health professional, comes out and takes your child by the hand and says, okay, I'm going to go give them care, and walks off with them while you're sitting in the waiting room. And most people, myself included, would want to know what's going to happen in that circumstance. Want to know what could happen to that child in the course of the treatment, what should happen to the child in that course of the treatment, and they should be okay with it. Either the child should be okay with it or the adult should be okay with it. So those are the kind of things that you need to think about. You need to personalize this to some degree to get a sense of the needs that you need to make sure happen in that kind of context. Well, going back to our specific child here, uh, the most important thing is to see if the child understands the impacts and the implications of the treatment. There is no specific age of consent in Ontario for when a child can consent to treatments, but obviously we know that at certain points there's um, the ability to understand the implications of a treatment or those other kinds of things associated with the care. And so that's the judgment you need to make. But you initially need to make your assessment or your consideration of those things with the child directly. And if you come to the conclusion that the child's not yet sufficiently mature to understand those things, you need to then speak to either the child's parent if the child's if available, or some other substitute decision maker. But that's what we're really talking about is that ability to, first of all, make sure the child or the substitute decision maker understands all the relevant information necessary. And secondly, give that child and then consequently the substitute decision maker at least the benefit of the doubt in terms of their capacity to respond to that treatment. So was that the sort of answer you were looking for, Fiona?
That's perfect. And I think what you're bringing out is the discussion component. You need to have evidence through the discussion that the patient understands and is able to consent to the treatment. And I talked about the BRAN. BRAN is the benefits, the acronym, the benefits, the risks, the alternatives, or having no treatment at all. Does the patient understand that? And if they do, they can consent, they can provide their consent to you. They're capable. That's the capacity for the physiotherapy treatment. But the next question is very similar in a sense, but the other end of the scale. What if the patient's elderly has a dementia process? What do I do then? And I think, Rod, you said you have to have, as a physiotherapist, evidence from that patient that they understand or they don't understand the care that you're proposing. And if they don't understand, you'll go to, as Rod said, the step 2, the alternate decision maker. But patients do have the right, they have the autonomy. We respect their autonomy to make decisions about their own health care. And a patient with dementia may be lucid, they may be able at certain times of the day or week to provide that consent to you. And I think we need to give them the respect to be able to do that. There may be times they just cannot. And that's absolutely, you've got the evidence. And you would go and find a family member or the substitute decision maker that could make those decisions. But for that window of treatment, that elderly patient who you want to perhaps do some gait education with, they may be able to, at that time, that day, be able to consent. You may return later on that day and things may have changed and they may not be able to consent at that time and you'll need to do something different. So again, it's up to you, the regulated physiotherapist, to make that call.
Can I just speak one additional little bit about that. I think it's sometimes, and I know it's difficult because you're limited by the amount of time you have to assess patients and talk to them and that sort of thing. But I think it's often very helpful to just spend an extra minute or two talking to patients, especially the elderly patients. I know, for example, my own mother, she has aphasia and she's deaf. So she's very difficult to understand, and it's very difficult to help her understand. But those extra few minutes make a big difference in helping her understand the implications of what you're going to do and what she needs to understand in that context. So that's the kind of thing. I mean, don't automatically assume that because she looks at you with a blank look on your face that she doesn't understand. You need to just take that extra moment and settle her in and speak to her. So just as an example, sometimes that's a really useful thing to do.
Thank you for that example. And that moves me to the next. People often ask about written consent. So I do want to address that. You and I have spent most of our time discussing the importance of the conversation you're having with the patient. That's about consent. I've got many questions here about, do you need a written consent form? What do you need to write? Yes, our standards, you would need to write in the patient record that you've had that discussion and the patient's consented or not. But if the patient's consented, you would need to make a note in the patient's chart. A consent form, we're asked many questions, do we need that form? A form is a good addition to that discussion you've had with the patient. It shows that if the form has a list of things that you've discussed with the patient and you've asked the patient to sign, that's certainly an addition. It's a good thing, but it isn't necessarily the most important thing. The most important thing is a discussion. So what do you need to write that you've gained consent? There needs to be evidence to the reader that you've had a discussion with the patient and you've covered the benefits, the risks, any alternatives with the patient. We do have a few examples on our website. We put them up recently. If you go to the standard, then you'll see on the right-hand side, we've posted a few examples of consent, and it can be very long and detailed, certainly when the risk is high. Perhaps the procedure is invasive or sensitive in nature. You certainly want to be writing a little bit more about that discussion you've had. If the risk is low, the patient has full understanding, you might want to write a little bit less. But have a look at those examples and that might give you some idea of what might be appropriate in your practice. Okay, I'm going to move on to the next standard, and that's the supervision standard, because we do get a lot of questions. Look at the standard, there's 6 sections to that standard. Let me just give you a little bit of an overview of it. Same theme, the physiotherapist, you are responsible, you're accountable for assuring the standards of the profession are met by anybody you're supervising. You could be supervising the PTA, you could be supervising a student, or a physiotherapist resident. You need to have a ways of giving yourself confidence that any of those roles, the person you're supervising is competent. And it could be done in various ways. It could be through direct observation with the PT resident. You may have scheduled teleconferences where you review charts. With the students, again, it might be direct observation. You might be going through charts. If you're supervising a PT resident, we do need you to keep records of how you ensure ongoing assessment of competency. If you want some ideas of how you might do that, we do leave it up to the physiotherapist, but I do have some ideas. You might want to do a chart simulated recall. You might want to review a patient over the phone. You might want to have direct observation. But again, keep that record. You do not need to submit it to the college unless the college reaches out and asks you for that information. With students, a little bit of a different rule. You do have to co-sign their notes. Remember, a student is in a process of learning and they will eventually become a professional, so you do need to document that, or provide your signature that you've reviewed their record keeping and you believe it's adequate at that time. You do not need to co-sign the PTA's record, and you do not need to co-sign a PT resident's record. There are a couple of other, when you're supervising a PT resident, you have a mandatory reporting obligation if in the course of supervising you do unfortunately discover that resident is either incompetent, has been engaged in misconduct or sexually abused a patient, then you must make a mandatory report to the college. That's the requirement. So again, I think that sums up the high level rules around supervision. I'm happy now to go to some of the questions that have been submitted. The first one, could you discuss the roles and responsibilities of both the PT and the student to receive consent for involving a student in the patient's care? I know we had a case of the month. I know we highlighted it's very important that you get consent for involvement of student in patient care. Now that can be the physiotherapist going directly to the patient and asking if they're comfortable with the student being involved, or the physiotherapist can ask the student to have that conversation with the patient, describing their role as a student, and ask if the patient's comfortable with them being involved. Also give the patient an out. If the patient for some reason doesn't feel comfortable, then they can certainly ask for care being delivered by a physiotherapist. So it can be either or, it can be both. What I haven't really mentioned is you should make a record in the patient's chart that they have consented to the involvement of the student in their care. So another one, supervising provisional physiotherapists. How can a supervisor role provide adequate supervision if the provisional physiotherapist potentially works at another site or somewhere where the supervisor doesn't work? So that really is up to the physiotherapist. You need to have a method of determining whether the PT resident is competent and able to deliver care. So I touched on it before. You could meet with the resident. You could have a process where you review charts together. You could use the digital technology. You could use video technology. You could meet and go through a patient's care and that will give the physiotherapist confidence in their ability. It might be that you don't have the confidence and you're not able to supervise because of what you found. In that case, yes, you're right, you would not be able to supervise from an alternate site. You would either have to change up so you are directly with the resident, or contact the college to say you can no longer supervise this PT resident and why. Another question, what happens if a provisional physiotherapist does something he or she ought to know is not right? Fraudulent claims, or they've crossed a boundary. I did mention this before. The physiotherapist does have a mandatory reporting obligation. So if they've noticed a PT resident, or they have evidence a PT resident has sexually abused a patient, or has made fraudulent claims, then they absolutely would have to report that to the college, and you would go to our college website and you can make a report either online, or you can call us and one of the coordinators will be able to take that call. But remember, the supervisor, you're accountable to determine the level of knowledge and skills of the PT resident and to ensure that they can meet all of the college standards. If there's a gap in any of the standards, it's the supervisor's role to try and address those gaps, to provide training, knowledge, experience in order to bring the PT resident up to the level where they're meeting standards. And if not, then you let the college know you're unable to do that. And remember, keep a record of any supervision you've done with the resident. Keep that. You don't need to submit it to the college. Only when maybe the college reaches out and asks for a record, then you need to produce it and submit it at that point. Okay. Okay, we're moving on. We've got the record keeping standard. The record keeping standard is a little bit longer. There's 6 sections to the standard, and you really should be aware of what's expected when you maintain a record. Remember, every patient that you're involved with, you need to keep a patient record. That you're accountable for maintaining an appropriate record of the assessment or the treatment. You need to have an assessment in that record. You need to have a working diagnosis formed. You need to have a treatment plan, a transparent treatment plan. And if you've involved an assistant in the care, there needs to be a record of that. There needs to be sufficient clinical data, objective measures to really support and reason the need for physiotherapy being delivered to that patient. The physiotherapist may not be the health information custodian, I'll call them the custodian for short, but somebody needs to be designated as a custodian for the record keeping for the patient's chart. So if you work in a hospital, by default, the hospital is the custodian for the patient's record. If you work in a clinic, there needs to be a designated, it's probably the owner, the regulated health professional, or the owner that's the custodian. But when you go to work at a clinic, make sure you understand who is the custodian, because that record needs to be kept for 10 years after the age of the patient turns 18. And you need to be aware that there's privacy and there's security measures in place to ensure that the right person at the right time gets access to the patient's record. That's a very quick nutshell of the record keeping standard. So I'll maybe take some questions now. First one, do we have to make chart notes for every single visit? The answer is no, you don't need to make a full note every time, but there does need to be a record of your attendance. It might be an attendance checklist or your workload measurement system in a hospital. We need to know that that physiotherapist or that assistant treated that patient at that date and provided that particular service. So in summary, every professional encounter needs to be recorded somewhere. Notes should be made for an assessment. They should be made for a reassessment if the patient's condition has changed, or if you alter any part of the patient's treatment plan, there needs to be a record made in the patient's chart. Next question, how did I make sure treatment notes made on a computer are not altered by anyone else in the clinic, as the owner has a password to allow to edit or to delete a note? Well, that's a wee bit concerning. Your record, your physiotherapy record of your patient should be your record, and it should not be altered or deleted by anybody else but yourself. If you do need to alter anything, a line through a record that you've altered on the date that you've recorded and what you've changed should be made. But an owner who's not directly involved in the care of a patient should not be making any change to the record. So that's a little bit concerning. I would certainly maybe audit your record, make sure there's not been any changes, that you're the only one making a note of the treatment that you've provided. I would say if you are concerned, you're concerned about the clinic owner, sit down with the owner and talk about the record keeping standard, talk about how it applies to you. You're the person providing the care. You're the one that needs to keep a record accurately and honestly of the care provided, and they should not be making any changes. If that concern grows and continues, and perhaps you've left that clinic, you might want to put a tip online about the owner, the Canadian Life Health Insurance Association. Their website, and we do have a link to it on our college website, has a tip line that you can share some information about what you think or you're suspicious of that's going on at that clinic. But hopefully having a direct conversation with the owner of that clinic, sharing that standard, sharing what the expectations are, will clear up any misunderstandings. Next question, does the information on who provided care on a specific day need to be in the patient's chart? I think I addressed that in the first question. Yes, it can either be through a note or it can be through an attendance record or workload measurement system identifying who provided a service on a certain day. How do you ensure that a patient's charts are well taken care of once you leave a practice? I think that goes back to you've designated or you understand who the health information custodian is. That custodian has the responsibilities of maintaining the record for the appropriate length of time, 10 years after the patient turns 18, and keeping it secure, keeping it private, and as Rod had talked about earlier, making sure the right person has access and only the right person has access to that record. There should be policies in place, but how do you know that that will be taken care of? By knowing that there is a designated health information custodian, by knowing, having a conversation with that custodian, that you can be assured that the record keeping will be maintained appropriately. Would you add anything to that, Rod?
I don't think so, no, Fiona. But I think one thing that we should be always thinking about is why we make the records. And I don't think you touched on this specifically, but over the course of your questions, there's a a need for continuity, and you think, why do I need that? And it's a lot of the times it's because there may be a day when you're not there, or that the patient may not remember, or you may not remember. And so that's really the important thing to remember about records is that we need them, not necessarily just because it's a rule of the college. We need them to provide really safe care in a situation where a patient may not remember why they got the care, or the physiotherapist may not know why the care was provided. So we need that for ongoing continuum of care, and we need to make sure that we can pick up the patient's care based on the records and not make assumptions or hopefully try to get that information from the patient directly. So the record is very useful in providing safe and careful ongoing care.
Thank you, Rob, because that leads really nicely into the next slide. I'm going to talk about transitions and care. But I want to pick up on that point. The record keeping is the best communication tool that you have to talk with other care providers, to understand what's been happening, what the condition of the patient is, what the progress of the patient is, and what the plan for care is, and what the goals of the patient. Remember, the goals need to be recorded, what the patient hopes to achieve with physiotherapy. So the next slide I have is practice transitions. Now, we don't have a specific rule for practice transitions, but it really will depend on good record keeping. When a patient is moved from the organisation hospital to community, hospital to home, or clinic to clinic, the receiving physiotherapist is going to rely heavily on good record keeping. Before a patient is transitioned, though, from the hospital perhaps to home, I just want to put in a point. I do, as a practice advisor, talk to a lot of patients who call me, and they'll tell me that yes, they were in hospital, they had perhaps an arthropathy, they had a hip replacement, a knee replacement, or they had some procedure. And they said they know that the physiotherapist did explain to them what would happen to them when they transitioned from hospital to home. They know that the physiotherapist made a really good attempt, but due to the complexities of what was happening, due to the urgencies, to the acute care, the busyness, they completely forgot everything that they were told, is basically what they're saying. So they had left hospital, they had gone home, and now they're left with, what was it the physiotherapist had asked me to do? Who is it that I need to contact to continue my care? They've forgotten, they don't know. So I would just really urge physiotherapists, if you are transitioning a patient from the hospital to home, from a community or clinic to clinic, just understand the the patients may be anxious. They may not have absorbed all of the information that you provided. So verbal might not be the best. I'll leave it up to the physiotherapist to make that judgment call, but you might want to inform the patient through writing down some instructions for them. If it's perhaps a patient, they've had a hip replacement, they're going home, they're going to follow up a bundled care provider, you might want to write that down for them, maybe write down some alternates, maybe some services that they can follow up to get the care that they need. So remember, a handover as well, a good handover, good notes. If the patient's chart has clear goals, has a clear treatment plan, a clear plan of care, then the receiving physiotherapist is going to in a much better position to ensure the patient receives good and gets good quality care. We do know from research, I won't go into the research, but we know it's exactly at this point when a patient transitions in care where standards are not met, where there's real safety issues, and we're finding that the quality of care, patients do fall through the net. So please bear that in mind. So you have a couple of questions around this, and that's why I put this slide up. You had, how can I transfer care to another therapist if there is no one covering the unit consistently? I can understand that might be the case. The physiotherapist needs to consider the risks associated. I imagine this physiotherapist is talking about you're moving from an acute unit to step down or to an alternative unit where a physiotherapist um, isn't covering that unit. I would ask the physiotherapist to look at, is there any alternatives? Is there a program of care? Maybe components might be able to be picked up by a nurse assistant. If you lay that out, again, going back to good clinical notes, maybe there's other people that can pick up components of care. Maybe there's other service providers that you can utilize. Maybe there's patient's family that can follow up with aspects of a exercise program. If the physiotherapist, if you've identified that the patient requires aspects of physiotherapist, then maybe it's time to speak with the manager, to speak with the organisation to ensure that this patient gets the care that they deserve. Sorry, that doesn't answer completely, but it gives you some of things to think about. If this comes up a lot, this question, if a hospital physiotherapist has a patient who needs ongoing care after discharge and they've asked specifically to see you, that physiotherapist, is this a conflict of interest? Not necessarily if you put certain aspects in place to prevent a conflict of interest. You would certainly need to provide alternatives to that patient's. I would suggest at least 3 alternative physiotherapists, private physiotherapists that they could contact, or if they are eligible for government funded care, make sure that's available to the patient and they understand that. Make sure the patient really understands they're free and have the right to choose between yourself and the other alternatives, and they're free to do so. I am explaining there'll be no recourse, that you will collaborate with whoever they choose to be their service provider on discharge. And I think that would mitigate any conflict of interest. Very much about perception as well. So make sure that you record that you provided alternatives of physiotherapy care to the patient on discharge. But yes, it's certainly the patient's right to choose after being provided with alternatives. If they still choose you, they're free to choose you to provide care if that's something that you want to do. So we have only a few minutes left, and I just want to touch on the last standard, which is boundaries and sexual abuse. You know that the roadshow last year we talked at length around the boundaries and sexual abuse standard, but I just want to revisit it. It's standard, high level. Going back to the main theme, it's the physiotherapist's responsibility to ensure professional relationship with the patient is kept, and that you really are aware of the risks to that professional relationship, and you prevent it slipping into a more of a personal relationship. The physiotherapist must be aware of your role. A patient has come to you to receive care. You have the expertise to provide care, to relieve pain, etc. So you do hold that power in the relationship. Therefore, it's your responsibility to ensure that patient feels safe, that they are the centre for the patient's care, they're the focus for patient care, that everything you do will be in their best interest. A physiotherapist needs to be sensitive and develop a trust with that patient. The patient needs to feel safe that they can discuss, emotional issues that impact their care, really give you a full history of what the injury was or what the complaint is. Know that the patient may feel vulnerable. They may have had experiences that make them feel vulnerable, and it's the physiotherapists that really need to put measures in place to make that patient feel safe. If a closer and intimate relationship exists between the physiotherapist and the patient, it has, and there's good research to show it may impact your judgment. It might be a good idea to transfer that care to another physiotherapist. Be clear, a physiotherapist can never have a romantic or sexual relationship with a patient. A full year must have elapsed before even considering dating a patient. And that power imbalance I talked about, you must be confident that that has diffused. There is no power imbalance left. But remember, sexual abuse can be termed, there's three activities. It can be comments of a sexual nature, touching of a sexual nature, as well as sexual intercourse. That cannot happen between a physiotherapist and a patient. I'm looking at the time and we only have 1 minute left. So I'm going to hand back to Rod, who's going to give you a little update on the quality assurance program.
In 1 minute. Okay, well, point form, I guess it is. Practice assessment process. You've heard about it in the past. This is the new one. So we've completely revamped it. We've completed the pilot of the screening. We've completed the pilot of the on-site assessment. And there's no longer random assessment. The way we're going to do it now is the people who have never gone through, or the people who are furthest out from their last assessment, are the first people who are going to go through the new assessment. And so that's good news for those of you who've been assessed multiple times. You won't, you'll be at the bottom of the list. Let's see, what else do we have? It'll be a lot shorter. The first discussion, the screening interview, will only be an hour instead of 4 hours, and that'll be remote. And only if there are issues coming to light in that 1 hour discussion will you move on to the actual comprehensive assessment, which will be an on-site assessor coming to your practice. If that happens, then there'll be a report, and then the committee, the college QA committee, will consider what to do next. It's been very valuable to have all your input from the pilots, both pilots, and we've really undertaken some, I think, significant improvement as a result. And we hope to get the full program up and running again by the end of, or by the end of summer, early fall. And as I say, if you've gone through it before, take a deep breath. You're not going to go through it again for a little while. So I hope that's helpful. It's kind of rushed, but I wanted to give you a sense of what the true story is.
Okay, in the last 10 seconds, I really encourage people, give Pets Advice a call if you have any questions about the standards. We're available 8:30 till 5, Monday to Friday, and we really, really look forward and welcome your calls. And thank you for listening to today's webinar, Everything you must know about the rules.